co-primary endpoint was MACE, and that was a composite of all-cause death, MI, and stroke. And then the last co-primary endpoint was bleeding, and that we only looked for superiority. Let me continue. So this is the patient flow. In the end, we randomized 4,579 patients towards 2,095 abbreviated DPT and 22,284 in the standard DPT population. Some patients we lost to follow-up or withdrew consent, was quite balanced. And we analyzed our data initially for intention to treat, for the first two for the last endpoint and the per protocol endpoint. Per protocol analysis was done for the first two non-inferiority endpoints. Baseline characteristics and clinical presentation is presented here. Very well balanced, as you can see. I will not go into details, but it is quite balanced, and ACS population was approximately 40% of our patients. The beautiful thing is that on average, and that you can see here, on average 2.1 criteria for bleeding was per patient. So it's not that patients were only included if they had only one inclusion criteria, but they had to have more than, but on average 2.1 inclusion criteria for high bleeding risk was present. So it's really a high bleeding risk population that we investigated. Here you see some procedural characteristics. As you can see, a majority radial procedures, more than 80%. Also, it's an all-comer study, so left main treatment was done in more than 5%, bifurcation on the bottom approximately 4%, overlapping stents in 20%, and multivessel stenting was also performed in more than 25%. So that is quite an all-comer study. Here you have the first primary endpoint, NACE, and you, as you maybe already seen at the presentation and publication, there was no difference between the NACE, between the standard DPT and abbreviated DPT. And if we look more closely at what reached the non-inferiority margin, was highly significant in non-inferior, both strategies, that's abbreviated with the standard. And if we look at MACE, the ischemic events, death, MI, and ischemic stroke, we see again no difference between the standard DPT and the abbreviated DPT, 6.1 versus 5.9, and that also reaches the non-inferiority margin, and so we could say that it was non-inferior in the abbreviated DPT was non-inferior for the standard DPT, considering the ischemic events. And if we look at the bleeding events, we saw a significant reduction with the abbreviated DPT as expected. And that was defined as BARC 2, 3, or 5, and that was highly significant for superiority, and numbers to be treated to get a reduction was 35. You see the secondary endpoints as a global. Again, you see on average, you can see that on the ischemic stroke and on the bleeding BARC 2, there was significant reduction obtained with the abbreviated DPT regimen. Unfortunately, and a little bit as a surprise, we did not see a significant reduction in the major bleedings like BARC 3 or 5, but still a numerically small reduction. Of course, our study had some issues, some limitations. It was an open label study, and depth duration was heterogeneous. As I mentioned, it was open at the left at the discretion, what kind of single antiplatelet therapy the operator should use. And in our OAC population, and I will touch on that a little bit later, the standard DPT regimen was a little bit longer than what is currently now in the guidelines. We compared 3 months, at least 3 months triple therapy with 1 month triple therapy in our trial. So that is a little bit longer in the standard arm than normal. Also, non-inferiority margins were relatively wide, and the observed event rates were lower than expected. But even if we correct our non-inferiority margins for the for our lower event rates, and we aim at a hazard rate reduction of 0.3, then we have still reached our non-inferiority criteria for the first co-primary endpoints. And we don't know whether our results are applicable for other stents. But in conclusion, and that is that in patients with high bleeding risk who had undergone implantation of the ultra-vaso stent, the discontinuation of DPT at approximately 1 month, compared to a treatment of more than almost 6 months of DPT, was non-inferior for NET, non-inferior for MACE, for ischemic events, and superior for bleeding, as shown. And what is nice to show you, and I will touch upon two sub-studies that we already did on the master DPT study, and that was also presented at ESC and at TCT. There are only 2 sub-studies that were pre-specified and stratified. That was the patients that had oral anticoagulation. And to come back a little bit on our design, so if the patients were randomized at 1 month between abbreviated and non-abbreviated, then the patients were stratified for whether they had a clinical indication for OAC. If they had no clinical indication for OAC and they were in the abbreviated DPT, then dual antiplatelet therapy was stopped, single antiplatelet was continued, and if they had an oral anticoagulation, then again DPT was stopped, and single antiplatelet therapy was given only for 5 months. And that's a little bit according to guidelines. The current non-STEMI guidelines in Europe giving only antiplatelet therapy up to 5 months if patients are on OAC. If they were randomized towards non-abbreviated DPT and they had no indication for OAC, then DPT was continued for at least 5 months, depending on the clinical indications. For ACS, it was usually they had 12 months, and the stable had 5 months, additional 5 months. And if they had a clinical indication for an OAC, then DPT was at least continued for another 2 months, so triple therapy for 3 months and single antiplatelet therapy thereafter. And if we look at these specific subgroup, then you could see that 1/3 of our patients had indeed a clinical indication for OAC. They were, of course, this study was stratified, so it was quite very well balanced between the abbreviated and the non-abbreviated subgroups. I will spare you the baseline and the procedural characteristics. I can tell you they were very well balanced between the abbreviated and the non-abbreviated in both the OAC population and the non-OAC population. And if we look at the results, you can see that for NACE, we saw no differences in outcome for NACE between the abbreviated and the standard DPT. More interestingly, we saw again no difference at all in ischemic events between abbreviated and non-abbreviated, as well in the OAC population, as well in the non-OAC population. The OAC population is the solid lines, and the non-OAC population are the dotted lines. But you can see there are no differences, and very consistent results. The p-value for interaction is not significant. Only in the bleeding, we saw some differences. First of all, I think it's interesting to see that patients on the OAC are, in my eyes, the highest at risk for bleeding, more than high bleeding risk patients on other criteria. So patients on the OAC are the highest at risk for bleeding. And here you can see that the abbreviated DPT arm in the OAC population is numerically lower than the standard DPT arm, but it did not reach statistical significance. Only it reached statistical significance, the reduction in bleeding in the non-OAC population. And that's 2 reasons. One reason is that the OAC population, I think we were a little bit underpowered to detect a significant reduction. And second, we also noticed some problems with adherence. Not all patients stopped antiplatelet therapy in the abbreviated DPT arm after 5 months. But nevertheless, outcomes were quite good. As you can see, numerically, all events were lower for the abbreviated DPT, for ischemic, and significant for stroke, and numerically lower for bleedings. And in the non-OAC population, we have a significant reduction in BARC 2, 3, and 5 bleeding, which was mainly driven by BARC 2 bleedings. So in conclusion, concerning this subgroup, that in the master DPT trial, the OAC subgroup analysis, 1 versus 3 months DPT in 1,600 OAC patients and 2,900 non-OAC patients, we see no differences in ischemic events between abbreviated and standard DPT, and we see a reduction in bleeding, significant in the non-OAC population, but unfortunately not significant in the OAC population, but that is due to 2 reasons that I just alluded to. This is the summary, and then the last subgroup that I would like to share with you, and is I think of the most interest, is the one where you have the bi-risk patients. Patients on one end high bleeding risk, and on the other hand high ischemic risk by the fact that they had an ACS at index PCI or an ACS in the 12 months before they were randomized. So the prior MI group, that is how we defined our group. And it was also a pre-specified and stratified subgroup analysis within the master DPT trial. And again, it's the optimal duration of antibiotic therapy in high bleeding risk patients with an acute coronary syndrome remains unclear. And specifically, these high bleeding-based patients are presented with a clinical dilemma. And we report in this study on our specified and stratified subgroup analysis about whether patients with an acute MI at baseline or previously, therefore, had a more ischemic risk or not. Again, so you can see that the patients with a prior MI, again, 1/3 of the total population had a prior MI, meaning had an MI at index or shortly therefore. And we looked at what the effect was on the abbreviated DPT versus the non-abbreviated DPT in those patients. Here I will show you some baseline and procedural characteristics. Again, because it was stratified, the differences between the abbreviated and non-abbreviated for the baseline characteristics are quite well balanced. The only differences is, of course, that in the prior MI group, all patients had, of course, a STEMI or a non-STEMI, whereas that was not present in the prior MI group. So the prior MI group consisted in our study that they had an acute MI at baseline in 95%, or a history of MI within 12 months in only 5%. So that is the prior MI subgroup that we looked at. And if we look at NACE, we see something interesting. We see in the no prior MI group, no differences in NACE at all. But in the prior MI group, we see that in the abbreviated DPT, numerically, we see lower NACE rates compared to the non-prior MI group, which was more or less the stable angina patient group. And interestingly, if we look at ischemic events, again, we see no differences between abbreviated and non-abbreviated for ischemic events in the no prior MI group. And we see, again, also no statistical significant difference, but numerically lower ischemic events in the abbreviated DPT arm, as you can see here. And then for the bleeding, a very consistent result, again, as well in the prior MI group as in the no prior MI group, we see a significant reduction in bleeding with the abbreviated DPT arm. So in summary, ladies and gentlemen, and that's 2 more slides extra, all-cause death, no differences in between abbreviated and non-abbreviated in both subgroups, very consistent, and also for myocardial infarction. And also myocardial infarction, I think that's the most interesting one. No differences between prior MI and no prior MI in the abbreviated and non-abbreviated DPT arms. In summary, here you can find again the results in the prior MI group and the no prior MI group. where you have significant reduction in bleeding, mainly driven by BARC2. And in the subgroup of 1,780 prior myositis ACS patients, we see in ischemic events no signal whatsoever on increase of ischemic events with abbreviated DPT and a significant reduction in bleeding events, and very consistent results between recent ACS and non-ACS patients. Well, this is the last results that I can share with you from the master DPT. More will come out later on complex PCI procedures like bifurcation stents along lesions, etc. But that I cannot share yet because we have not analyzed that completely. I'd like to thank all our investigators and local PIs, and of course Alfredo for Southern America, and of course our partners that have been very instrumental in doing this trial. And thank you for your attention, and sorry to give you so much slides in a short period, but maybe you have some questions left. Thank you. Hello.
Nice, Peter.
Thank you. Let me try to put you in image again. Let me stop sharing. Good, thank you.
Thank you, Peter. Excellent.
Alfredo, you're on mute.
Doctor Rodríguez está muteado, no se le escucha. Doctor Rodríguez.
Sorry, I'm sorry. Yes, Peter, if you like, we can have 10 minutes to make a discussion with you to allow you to leave the session if you wish.
Happy to answer any questions, if any.
Okay. Listen, to be clear, abbreviate DAPT. What that means? You stop 100% DAPT or means single PT?
Yes, you stop 100% DAPT at 1 month. That means abbreviated DAPT in our trial. You stop DAPT at 1 month in high bleeding risk patients, and you continue with single antiplatelet therapy. And that we left at the discretion of the operator. So you could continue with clopidogrel, or you could continue with ticagrelor or prasugrel or aspirin. Actually, we left it at the discretion of the operator, and I think that's the best solution because they know best whether the patient is at high ischemic risk as well, and if the patient and what the clinical indication was, and in those patients you might have a preference to give a single antiplatelet therapy, which consists of a potent P2Y12 receptor blocker like ticagrelor or prasugrel.
Okay, that is important. Okay, Doctora Curoto and Doctora Sandra, would you like to have any questions?
Yes. Good morning. Thank you for these excellent lessons for us. It's very important for us, the sub-analysis of the high-risk ischemic risk patients and with high bleeding risks. That is, for me, the most important and the most challenged patients for us. It's very important for us your numbers and the security that the abbreviate DAPT for that high risk ischemic risk patient is safe, and that results are very important for us for future investigation. In the high risk, this trial is very important because it includes high bleeding risk patients, and in these patients who need anticoagulations with NOACs it's a very large population of patients for us. And do you think that this trial will be the start for another trials to compare the monotherapy with the other drugs and with other stents? It's very important for us, this trial, to start another trials
if I understand you, Valeria, you are asking about is we can do it another trial, yes, directly, no abbreviate, with single antiplatelet therapy versus normally DAPT therapy. Do not include abbreviate. You start immediately after PCI with clopidogrel, prasugrel, or ticagrelor, for instance, compared to DAPT. That's what do you mean, or is that right?
Yes, I want to ask him what he thinks about it.
Yeah, well, thank you very much. First of all, thank you for your comments about the Master DPT study and the sub-studies that we performed so far. And you raise actually two questions, I believe. First of all, is it worthwhile investigating, for instance, a monotherapy study in compared to a dual antiplatelet therapy study? I think that very much depends on whether that should be done in patients with an OAC or not. The current guidelines in OAC or NOAC patients advise you to give during the maybe up to 1 month, 1 week of dual antiplatelet therapy and then stop DAPT and continue with single antiplatelet therapy, whereas we only investigated 3 versus 1 month triple therapy. How much further we can go down, whether the 1 week triple therapy or even peri-procedural triple therapy and then single antiplatelet therapy, that is something that it still needs to be investigated.
Yeah,
it's already there in the guidelines, but we see from meta-analysis that there is some increase in stent thrombosis if you only give dual antiplatelet therapy during the procedure or only in the first 1 or 2 weeks. So it would, but still, it's going to be interesting to investigate. That has never been done actually. Whether you can do that also in non-OAC patients and in an all-comer situation, that I think is a nice question for Adnan Castrati, who is also in the CECI meeting, because he is going to perform a next study on this, so that's going to be a good question for him. And then you also questioned about if our results are applicable for other drug-eluting stents, or should we do a comparison? I think that we don't know. That's my honest answer. What I know is that with the Ultimaster stent, I'm very confident that I feel very confident that I can stop dual antiplatelet therapy after 1 month in my high bleeding risk patients. If that is true for other stents, it could be so, but I don't know. It's a question.
Yeah.
I think that's an honest answer.
Thank you, Peter.
Thank you.
Sandra, would you like to make a comment on Dr. Rodriguez Granillo? Matías?
Yes. Hello, good morning. Thank you, Dr. Smith, for your explanation, very clear. But I have a question, because it's different the patient with coronary care, with acute coronary syndrome, and the patient that don't have acute coronary syndrome. The DAPT for patient with acute coronary syndrome, previous trials show that it's better. That's why we continue with DAPT in patients with acute coronary syndrome. But your results show that it's the same.
Exactly.
But a lot of previous trials show that it's not the same, the DAPT or simple APT in patients with acute coronary syndrome.
Yeah, that's a very good question. Indeed, but I think we can also acknowledge that the field has progressed. We are implanting now new generation stents, which have a better results than 10 or 20 years ago. We are using as monotherapy more potent P2Y12 receptor blockers, and in fact, if you look to very recent studies, you're right. You have the stop DEPT2 ACS results. We can recap that study. It's a study from Japan. They looked at 1 month DPT in ACS patients. They stopped after 1 month in ACS patients, and they continued with monotherapy clopidogrel. And in that specific study, non-inferiority on NACE was not met because they saw an increase in myocardial infarction in the abbreviated DPT arm. But our studies is a little bit different, not only for the fact that we are investigating high bleeding risk patients, but more importantly, we left the monotherapy at the discretion of the operator. And what we saw is that patients who had a ACS at index or shortly before, a large proportion of those patients received monotherapy of ticagrelor and not clopidogrel. And specifically in a Japanese population and Asian population, clopidogrel, where the responsiveness is not that great, sometimes where you have a lot of non-responders, maybe that was not such a good idea. But if you want to mitigate, if you want to abbreviate your DPT regimen in your ACS population, I think it's not so bad idea to continue with single antiplatelet therapy, but don't give aspirin, don't give clopidogrel, but give, for instance, ticagrelor or prasugrel.
Thank you.
Dr. Matthias, would you like to make a question?
Yes. Hello, Dr. Smith. Thank you very much for this opportunity of being in this symposium. My question was about what you were talking about just a couple of minutes ago about the clopidogrel, the ticagrelor, and prasugrel. If there was a difference in the prasugrel, if you are going to use single monotherapy, if there is difference between prasugrel or ticagrelor in thinking about the React 5.
Yeah.
Also, there any comparison about that, or we have this information of the Japanese?
Also, beautiful question. Indeed, interesting enough, there was some in the ISO React showing some benefit of prasugrel above ticagrelor. Funny enough, in our global trial, only 1.5% of our patients were treated with prasugrel. I don't know why, but so the prasugrel population was severely underrepresented in our trial. It was predominantly ticagrelor that was given as the more potent P2Y12 receptor blocker. Of course, according to the guidelines, the majority of the patients received clopidogrel, specifically those patients with an OAC and the patients with stable angina, but the patients with ACS or ACS history, they received predominantly ticagrelor and not prasugrel. So difficult to answer.
Okay.
Thank you.
Any comments? If not any comments, we will move forward. Peter, you can stay, you can leave, whatever you want. Many thanks again for your support every time I ask to you to be with us. So many thanks.
It's a pleasure. I have still some work to do, so I hope you will excuse me, and I wish you a good meeting.
Of course. Thank you again.
Okay.
Thank you again.
Okay. Bye-bye.
Bye-bye. Merry Christmas. Merry Christmas for you.
You too. Okay.
Nuestro próximo lecture va a ser el doctor Carlos Fernández Pereira, que nos va a hablar cuál es la indicación para ticagrelor, prasugrel y clopidogrel en síndromes coronarios agudos, la evidencia a través de los registros. Doctor Fernández Pereira.
Gracias, doctor Rodríguez. ¿Lo compartimos en inglés o seguimos en castellano, como usted prefiera? No.
Ahora hagamos castellano, me parece, los slides están en inglés.
¿Ven la pantalla?
Se ve muy bien.
Ok. Bueno, muchas gracias por la invitación. Es un tema muy apasionante de nuestra vida real. Todo esto ha sido publicado previamente en esta revista. Este diapositivo seguramente lo conocen todos, es referente al prasugrel y el clopidogrel, y el gran resultado que tuvo ya en este trabajo del año 2007, el cual es mucho más potente el prasugrel que el clopidogrel, que hace su pico a las 2 horas y es mucho más efectivo que la dosis de clopidogrel. Tiene menos infarto, pero tiene más sangrado. Entonces, es una alternativa al clopidogrel, pero tenemos que tener mucho cuidado en lo que tiene más por la edad de 75 años y por el peso. Y discontinuarlo 7 días antes de la cirugía, pero la FDA nos ha advertido que no lo podemos usar y tenemos que evitarlo en el ACV o en el accidente isquémico transitorio, en cuál son sus contraindicaciones. El estudio Plateau, que también ustedes lo conocen, comparaba el clopidogrel y el ticagrelor. No hubo un incremento de sangrado entre estos dos, pero hubo una reducción significativa para el ticagrelor en mortalidad cardiovascular, infarto y en trombosis. Pero si ustedes ven en qué poblaciones tenía más peso o más cantidad de pacientes incluidos, fíjense que fueron Hungría y Polonia, en donde los centros de control estaban precisamente monitoreados por el laboratorio que sponsoreaba el ticagrelor, y ese es el peso que ustedes están viendo ahí a la derecha. Pero si ustedes ven, en Estados Unidos únicamente no hubo diferencia, inclusive había menores eventos en el clopidogrel, y eso lo mismo se ha sido representado en Taiwán, Australia, inclusive con mejor efecto con el clopidogrel, y eso es lo que queríamos establecer en forma clara, que hubo una diferencia a favor del clopidogrel. Lo mismo una población en Asia, por ejemplo Japón, Taiwán y Corea, comparando ticagrelor y clopidogrel, de los eventos fueron un poco más altos, pero la seguridad y la eficacia fue en el grupo ticagrelor, pero era un grupo muy pequeño para esta población, pero la verdad que tenía muy buen resultado con el clopidogrel. Y en este estudio, en el cual vemos qué respuesta tiene en la población sana, ustedes ven que el ticagrelor y el prasugrel tienen una respuesta casi similar, superior al clopidogrel, pero en cuanto a reactividad residual, comparando el prasugrel y ticagrelor, hay una reactividad residual aún superior a inclusive a 8 días con el ticagrelor, que se vuelve a presentar, lo cual puede representar cierto riesgo para el paciente. Y en el mundo real, en este estudio comparativo de prasugrel y ticagrelor, en una base de datos en Estados Unidos, ahí todos los procedimientos se meten en una base de datos en cada estado, y este es un estudio de George Vetrovec, en el cual en el mundo real los médicos prefieren realmente utilizar el prasugrel en gente más joven y tiene mucho menos riesgo de sangrado o comorbilidades. Y estas son las diferencias, realmente son contundentes a favor del prasugrel. Eso tanto en los eventos netos a 30 y 90 días, como en eventos mayores cardiovasculares a 30 y 90 días, e inclusive en el sangrado. En este metaanálisis, por ejemplo, que esto ha sido, pertenece a, o sea, han participado dos que han sido invitados nuestros al CECI habitual, como la doctora Roxana Meran y el Peter Berger, que tiene numerosos trabajos en antiplaquetarios. Y estos son pacientes con infarto, con ST, luego de la angioplastia. El prasugrel y ticagrelor fueron mucho más eficaces que el clopidogrel, pero el prasugrel fue a su vez superior al ticagrelor, en particular cuando se usa con bivalirrudina, que lo estamos usando poco, y stents con droga. Estos, con los eventos a un mes, a un año, la mortalidad y todas las causas de mortalidad, así como también en el sangrado, al mes y al año, ha sido muy evidente. Y en estudios europeos, comparando todos estos tres mismos medicamentos en mortalidad intrahospitalaria, a un año de mortalidad, a un año de mortalidad cardiovascular y sangrado mayor, en todos ellos, el resultado es superior con el prasugrel comparado con los otros dos. Entonces, todos estos datos nos da a favor del prasugrel por encima del ticagrelor en los pacientes, en este grupo de pacientes agudos, y se han publicado en estudios y registros como la dice REACT, el Popular Age, el registro británico, que lo vamos a ver, y el registro de Suecia. Todos estos a favor del prasugrel. Por ejemplo, el registro británico, en el cual me introdujeron más de prácticamente 90.000 pacientes, en el cual se dieron clopidogrel, prasugrel o ticagrelor, y ven los resultados realmente son muy favorables al prasugrel. Y conclusión, esto es precisamente muy contundente en el sentido que el prasugrel está asociado con menos mortalidad 30 días y al año comparado con el clopidogrel, y se pregunta si no sería bueno que esto tendría que tener una implicancia en nuestra práctica clínica habitual, dado la gran cantidad de pacientes que fueron registrados. Esta es la gran ventaja de que ellos tienen un registro que es obligatorio en cada hospital, y con lo cual estos datos son realmente muy verídicos. Lo mismo si en este estudio en el cual no se demostró, este es el registro sueco, en el cual el resultado no dio significativamente superior, no fue superior al ticagrelor si lo comparamos al clopidogrel en pacientes con síndrome coronario agudo posteriormente a la angioplastia, como se muestra en esta diapositiva, sobre todo en la curva de mortalidad. No hubo ninguna diferencia entre el ticagrelor y el clopidogrel en este estudio. Con lo cual, las implicancias son, como en este estudio, no se pudieron realmente validar el estudio Plateau en este estudio, en este registro, por lo cual realmente ellos siguen utilizando el clopidogrel por encima del prasugrel. Y en el registro del Popular Age también, en estos pacientes de más de 70 años, uno pensaría tendría cuidado con el sangrado, fue realmente el clopidogrel fue mucho más favorable al ticagrelor con respecto sobre todo al sangrado. Eso es lo que más nos preocupa en los pacientes de esta edad, y los eventos combinados de muerte, infarto, stroke y sangrado. Por lo cual concluyen que el clopidogrel es realmente la alternativa para usar en este grupo de pacientes de edad que tienen, como han visto en el trabajo de Master de IPT que recién presentó Peter Smith, es un grupo de más alto riesgo de sangrado. Lo mismo se muestra en esta curva de Kaplan-Meier de alto riesgo de sangrado, y en el Popular Age, este es el estudio que se ha mostrado, el clopidogrel en pacientes de más edad. Estos pacientes tienen alto riesgo de sangrado, y insistimos, el clopidogrel es mucho más favorable al ticagrelor. Esta es la conclusión que hemos mencionado previamente. ¿Y qué pasa en Argentina? Nosotros hemos unido en varios estudios, el ERASI y el WOLS, comparando el clopidogrel, el ticagrelor y el prasugrel, y ustedes como ven, inclusive el clopidogrel tiene muy buen resultado, y en el segundo, en cuanto a eventos, menores cantidades de eventos es el prasugrel, y tenemos mucho más cantidad de eventos en el grupo de ticagrelor. Y hay diferencias entre el estudio Plato y el Tritón. En el Plato fueron más, una estrategia más conservadora, menos angioplastia comparado al Tritón, y hubo menor cantidad de inhibidores de glicoproteínas en el Plato que en el Tritón, y hubo diferentes definiciones de sangrado en ambos estudios. Entonces, hasta el presente, si nos fijamos en la literatura y vemos los numerosos estudios de registros, realmente no hay no estamos viendo el resultado que se estudian, que se ven en otros previos referente a la superioridad ticagrelor sobre el prasugrel, y tenemos menos eventos y de mortalidad de MACE, o sea, de eventos cardiovasculares mayores, y eventos netos como el NACE con el prasugrel, y eso es lo que seguramente va a tocar el doctor Castrati, que debería ser incorporado a nuestra práctica diaria, y sobre todo en las guías en cuanto a este grupo de pacientes en cuanto al uso de DIPT. A su vez podemos, a nuestro juicio, de acuerdo al registro sueco y el Popular Age, nuestro juicio podemos elegir entre clopidogrel y ticagrelor, balanceando riesgo-beneficio. Esto es las conclusiones, y le agradezco mucho al comité organizador por permitirme presentar. Muchas gracias.
Carlitos, sí, yo creo que es muy importante. I would like I saw Anand Castrati is here with us, so we start to speak in English.
Excellent.
It's very important to think that the prasugrel bleeding risk is greater than clopidogrel, but not with compared with ticagrelor. In Triton, prasugrel have a high bleeding risk because the subgroup with glycoproteins 2B3A, if you use together with the prasugrel, that is the main reason of bleeding. That is the main reason of bleeding. So, okay, I would like to introduce Dr. Anand Castrati, which is one of the persons in the field who must randomized trials ever published. I don't know how many papers he published in PubMed Journal. And besides that, he is a very good friend of us. And we are doing a trial together. Anand?
Alfredo, thank you very much. Thank you also for having me and for inviting me to this meeting. It's a pleasure for me to be with you in this meeting. So this is my plan during this talk. Antiplatelet therapy in acute coronary syndromes. I would say some words about the selection of drug, the selection of time of initiation of the antiplatelet therapy, and something about intensity and duration of therapy in these patients. You have also read the guidelines, the most recent guidelines of the European Society of Cardiology. And with respect to patients with acute coronary syndromes, there is a preference for prasugrel as compared to ticagrelor in these patients. So, and you see that the recommendation class is 2A, and the evidence level of evidence is B, what means that it is one study, one randomized trial, which is ISA-REACT 5, that provided results to support this recommendation. In the ISARIECT-5 trial, we randomized 4,018 patients. There were 23 centers participating in this trial, and the centers were distributed in Germany and in Italy. These are the inclusion and exclusion criteria for the ISARIECT-5 trial. There was a very broad spectrum of patients with acute coronary syndrome that were included in this trial. It was sufficient to have patients who were hospitalized to get an invasive strategy with acute coronary syndromes. And here are the major exclusion criteria for patients in ISARIECT-5 trial. This is the flowchart showing the study design. I would highlight two characteristics, two features of the ISARIECT-5 trial with respect to the initiation of therapy and with respect to the maintenance dose. So for the initiation of therapy, you see here the difference between STEMI and non-ST segment elevation acute coronary syndromes in this trial. In all those patients presenting with STEMI, ticagrelor and prasugrel were started as soon as possible after randomization. And the difference in the type of initiation of therapy between ticagrelor and prasugrel was designed for patients with non-ST segment elevation acute coronary syndromes. We started ticagrelor as soon as possible after randomization in this patient, but before coronary angiography. And for prasugrel, we waited for coronary angiography. And if there was an indication for percutaneous coronary intervention, then we loaded with prasugrel. And this was in respect of the guidelines at the time. Ticagrelor was recommended as a pretreatment, and prasugrel was recommended only for PCI patients. The other difference is in the maintenance dose. You see that we have used two maintenance doses for prasugrel, 10 milligram for all patients except for those older than 75 years and also under 60 kilogram of weight. For ticagrelor, it was given the standard dose for all patients. These are the baseline characteristics of patients included in the ISARIECT-5 trial. You see that non-STEMI and STEMI were almost equally distributed. 40%, 46% of the patients had either STEMI or non-STEMI. Coronary angiography was done in almost all patients presented. And the treatment strategy was PCI in 84% of the patients. 2% had CABG, and conservatively were treated only 14% of the patients. Here are the main results. The primary endpoint of the trial was a composite of death, all-cause death, MI, and stroke. And you see the difference, 6.9% at 1 year for prasugrel and 9.3% for ticagrelor, which means that 26% significant reduction with prasugrel versus ticagrelor. If we look at the components of the primary endpoint, you see the differences here. One difference reached the significance level, which was in regarding myocardial infarction, with a reduction of 39% with prasugrel as compared to ticagrelor. But all the other components were in favor of prasugrel, although they didn't reach the significance level. It's important to say that the difference also regarded definite and probable stent thrombosis. You see the numbers here. Definite stent thrombosis was seen in 22% of the ticagrelor group and 12% in the prasugrel group. Importantly to say that the bleeding complications were not significantly different between the two groups. It's also important to highlight the fact that the difference between prasugrel and ticagrelor was maintained even after 30 days. So you see the curves here within 30 days and after 30 days for both STEMI patients and also non-ST segment elevation acute coronary syndrome patients. So if you try to explain the reduced ischemia, but without increase in bleeding with prasugrel, you have to mention the difference in loading between ticagrelor and prasugrel, and large proportion of bleeding is peri-procedural. So by avoiding the pre-treatment with prasugrel, we have probably reduced the risk of bleeding in these patients. And also the highest bleeding risk, we know that it is in the elderly and low weight patients. And exactly in these patients, we gave the half dose of prasugrel, but the standard dose of ticagrelor. As a demonstration of the effect of this dose adapting in the EASI-REACT-5 trial, I am showing here the results for the elderly or low weight group. And you see that ticagrelor is associated with a high risk of bleeding in these patients as compared to the half dose of prasugrel. And if you look at the other group of patients, neither elderly nor low weight group, so under 75-year-old and more than 60 kilograms of weight, you see that the difference is on the other side. So that means that prasugrel is associated with a high risk of bleeding as compared with ticagrelor. That means that by adapting the dose of prasugrel, we have avoided the increase of bleeding in patients in the group of prasugrel. What is the reason for the reduction of ischemic complications with prasugrel as compared with ticagrelor? We have a very large subset of patients, almost 600 patients with platelet function study, and this is the largest cohort of patients in whom the platelet function was evaluated between prasugrel and ticagrelor. And you see here no difference at all at baseline in the platelet function. And you see a difference in favor of prasugrel. The platelet function, the platelet aggregation was inhibited more by prasugrel than with ticagrelor in this patient. The difference was highly significant. Even in this small cohort of patients, of 600 patients, we could see an association between the platelet response to the drug and the outcomes at 12 months. And you see that the tercide here with the highest response to the drug has also the lowest rate in complications up to 12 months. Selection of time of initiation of therapy in patients with acute coronary syndromes. And you see here that pre-treatment is not recommended in all patients with acute non-segment acute coronary syndromes, irrespective of the drug. And for prasugrel, it was already years ago the recommendation not to give it before coronary angiography because the ACOS study results were not in favor of the pretreatment. Here is showed the composite of cardiovascular death, myocardial infarction, stroke, urgent revascularization, and bailout 2B3A inhibitors. And you see no difference at all between the group with pre-treatment with prasugrel and no pre-treatment with prasugrel. On the other side, there was a negative effect of pre-treatment as compared to no pre-treatment regarding the bleeding complications, which were higher with pre-treatment, 2.9% as compared to the 1.5% with no pre-treatment. So for prasugrel, it was clear there was no indication, there was no recommendation to give it as a pre-treatment in patients with non-ST segment elevation acute coronary syndrome. What is the situation for ticagrelor? We have the results of the EASI-REACT-5 trial in the group of non-ST segment elevation acute coronary syndrome, which was the largest group of patients in the EASI-REACT-5 trial. You see that there is a difference in ischemic complications between prasugrel and ticagrelor. Ticagrelor was associated with 41% increase in the risk of ischemic complication, death, MI, or stroke in this patient, although it was given as a pretreatment. And even in the first phase here, in the first period of 30 days, you don't see any benefit with pretreatment with ticagrelor. On the other side, there are increasing data showing that pretreatment is not beneficial even for ticagrelor. Here we have the data from the SCAR registry, and you see that no routine pretreatment was the case in the 3,600 patients, and in 10,000 patients, it was routine pretreatment with ticagrelor. And if you look at the ischemic complications, no difference at all. You see the p-values are all non-significant, but you see an increase in bleeding complications in the group of patients who got pretreatment. So here you see the different 20% reduction if you don't give pretreatment in these patients. What are the mechanistic insights in this? Do we need practically this platelet aggregation reduction in the time of PCI in these patients? We have some studies, compare crush, for example. The authors compared crush with integral prosumerate in patients with staining. And you see at the beginning of primary PCI, their platelet reactivity was much lower with crush tablets. But even with this effect here, the authors couldn't see any benefit with crush versus integral tablet. That means that the level of platelet aggregation inhibition at the time of PCI seems not to be crucial for the anti-ischemic efficacy. Another evidence came from the Alpheus trial, ticagrelor versus clopidogrel. Even here, you see after the loading dose, much more platelet inhibition with ticagrelor than with clopidogrel here. But even so, there was no difference in all ischemic endpoints with ticagrelor versus clopidogrel. On the other side, with ticagrelor, we had more bleeding complications, 58% increase in the risk of bleeding complications as compared to clopidogrel. There is a very recent meta-analysis, 7 randomized trials with more than 30,000 patients in which pretreatment was compared with non-pretreatment. And as you see here, all trials pulled together, there was no difference in MACE, in 30-day MACE, in favor of pretreatment. On the other side, there was an increase in bleeding complications, 51% increase in the risk of bleeding with pretreatment versus no pretreatment. That means that we have enough data now to show that pretreatment in patients with non-SS segment elevation acute coronary syndrome is not needed. Now, what's about intensity and duration? And you know, trials in that topic, tropical ACS proved the favorable effect of clopidogrel in patients with a good response to clopidogrel as compared to those who were treated with prasugrel. You know also the results of the Pegasus trial, in which high-risk patients needed also ticagrelor later than 1 year. And also you know the results of the Twilight trial, which showed that ticagrelor for ticagrelor plus aspirin was not better than ticagrelor alone after 3 months of therapy. That means we have enough trials showing that de-escalation of antiplatelet therapy is something that should be considered in patients with acute coronary syndromes. I have here put together a summary of the dual antiplatelet therapy in patients with coronary artery disease undergoing PCI. For chronic coronary syndromes, the preference is given to clopidogrel as compared to prasugrel and ticagrelor, and the duration, the standard duration with the class 1 recommendation is 6 months. But in those with a high bleeding risk, you can reduce to 1 to 3 months the dual antiplatelet therapy. But you have also the option to increase the duration to 12 months for those with a high ischemic risk, having for this a 2B recommendation. In patients with acute coronary syndrome, prasugrel is preferred to ticagrelor, ticagrelor is preferred to clopidogrel, and the standard duration is 12 months. But even here, in patients, you should be careful in patients with high bleeding risk. They can receive also 1 to 3 months of dual antiplatelet therapy. In those with a higher ischemic risk, you can prolong the duration of DAP beyond 12 months. In patients with atrial fibrillation plus PCI, clopidogrel is preferred to prasugrel and ticagrelor as part of the antithrombotic therapy, and the standard duration of triple therapy is 1 week, but you can increase up to 1 month the triple duration of triple therapy in patients with high ischemic risk. Thank you very much for your attention.
Thank you, Anand. Great presentation. Okay, we have 15-minute discussion here. We have a panel. I would like to ask Sandra again. And if Sandra, are you here?
Yes. Yes.
Okay.
I'm here.
Yeah.
Well, thank you, Dr. Castrati. I think it's very clear, especially the last slide, where you put the balance between the high risk ischemia and high risk of sangrado. How to say sangrado?
Bleeding.
Sorry,
Yeah.
bleeding. So I think that after all this trial, I think in this time we are more or less clear what we have to do with the DAPTs or just one APT, or especially in patients with high risk of bleeding. So in which kind of patient you prefer ticagrelor, or for you maybe nowadays there is no patient that you prefer ticagrelor?
So this is a great question. It's not that we have excluded ticagrelor from our armamentarium here. It's so first of all, patients who cannot get prasugrel, for those with a stroke history, for example, or TIA history, they are treated with also with ticagrelor. And there are also patients that cannot get PCI as soon as we wish to have it. And these are also treated with ticagrelor, because with ticagrelor you can treat patients up to a intervention that it takes time. So this kind of patients are treated with ticagrelor with acute coronary syndromes. Otherwise, prasugrel is the standard therapy.
Prasugrel, yes.
Yeah.
Like here in Argentina, I see there are different hospital, a lot of hospital. I don't know why, but we prefer ticagrelor. Maybe because of the history of plateau, or I don't know. But it's very common nowadays, besides the ESA React 5, that a lot of people continue to use ticagrelor.
I know that it's also the tradition. It's because for many years ticagrelor was the dominant drug in patients with non-SS segment elevation acute coronary syndrome. For STEMI patients, it's a balance. It was a balanced use between prasugrel and ticagrelor. And in Germany, probably a little bit more prasugrel than ticagrelor for STEMI patients. It was also before. But for non-SS segment elevation, it's the tradition of the use, because the recommendations were also for ticagrelor. Although in the older recommendation, it was written that both had class 1A indication. But on the other side, it was said that people with non-SS segment elevation, they should get pretreatment. And pretreatment was recommended only for ticagrelor. So in some way, the recommendation was to use ticagrelor for patients with non-SS segment elevation acute coronary syndrome. This combination between pretreatment and PCI, it was in favor of ticagrelor, because prasugrel was not recommended was discouraged the use of prasugrel as a pretreatment. And they had done the right thing because the evidence was against the use of prasugrel as a pretreatment.
Yeah.
It takes time until the new evidence is convincing people.
Yeah, and the cost of the different drugs is huge, is large. I don't know in Europe, but here in Argentina, the difference cost of among prasugrel and clopidogrel are quite similar, but it's much more expensive.
Yeah, because prasugrel is genericum. That's why.
It's not generic, but there are some local laboratories who made, yes.
Okay. Yeah.
It's not Lilly. Another question, Matias, Valeria,
hello.
Carlos.
Hello, Dr. Castrati. Thank you very much for your presentation. I have two questions. One is, do you have an explanation for the unfavorable results with ticagrelor in all the randomized clinical trials except of the plateau between ticagrelor and the other ones?
No, I have no explanation of that. And,
okay.
So I am not the right person to give an explanation for that. But the problem, what I see now, is that after ISAREF 5, the problem of ticagrelor is not prasugrel, it's clopidogrel.
Yeah, that's right.
In popular age. And the other.
I think that ISAREF 5 increased the courage of people.
Okay.
Yeah.
And the other question is, when you decide not to pretreat a patient, when you go to do the procedure, the angioplasty, is there a difference in the usage by the operator of 2B3A inhibitors, or no difference?
So you had to know that the ISAREF 5 was run in 2 countries, in Germany and in Italy. And most of the patients were included in Germany, for sure, as compared to it. So we had almost 700 patients included in Italy. And the remaining from the 4,000 patients was enrolled in Germany. Germany is not well known for the use of 2B3A inhibitors. It has always been like this. So there was no sympathy in the use of 2B3A inhibitors. So we had a very low rate of use of 2B3A inhibitors in this trial, which also reflects the reality in Germany. The reality is not to use it. And that's why, but I think that in Germany, you have to understand that in Germany, the interval between presentation and invasive strategy is short. It's probably shorter than everywhere else. And that's why I have to call your attention here. It's this no need for pretreatment is for patients who are planned to go quickly to the cath lab. I don't know whether the result would have been different if we would have waited longer before going to the cath lab.
Thank you very much, Doctor.
Yeah, I would like to ask you, to Adnan, if what do you think? How do you manage the escalation from ticagrelor or prasugrel in your case to clopidogrel? That's one question. And the other one is, it sounds like, well, in our country, for instance, and comparing to master DAPT, for example, we have many cases with many stents, the length, for example, at least 5-6 stents. And in contrast, in the master DAPT, there were only 38 millimeters. So maybe they were only 2 stents. So although they were very high risk for bleeding, they were probably low risk for angiographic risk, or maybe they prefer to use less stents. So they use only 1 month antiplatelet therapy full treatment. But on the contrary, here, I have patients that a long time ago with many stents, they don't want to stop the clopidogrel. But we don't have any evidence. What do you think about that? Do we need a study regarding the length of the stents and the length and the time to use clopidogrel or other antiplatelet therapy?
I think that your question is great, and but it regards more patients with elective intervention than with acute coronary syndromes, because in acute coronary syndromes we have a standard of 12 months of duct. We don't try to. So you know also that all those scores about bleeding, they are very imprecise. Why? Because the same factors that we know that are factors important for bleeding, they are also factors for ischemic complications. So it is very difficult to find out a score that is a distinct score for bleeding. What we know is the most important risk factor for bleeding is a history of bleeding. This is for sure. And only these patients with a history of bleeding, we try to shorten it and to also to switch to clopidogrel after at least 1 to 3 months, which is also the evidence. But this is a very small proportion of patients with acute coronary syndrome. Otherwise, we try to be very standard in these patients to get duct up to 12 months. But you are right in saying that there is a trend to continue on clopidogrel after 12 months instead of aspirin, which has been the standard before, because the evidence for aspirin is poor.
Yeah,
it's
very poor.
Very poor. It's per tradition that we are giving it. We don't have data about a protective effect of aspirin against stent thrombosis. But it was given, and all patients with the coronary artery disease are taking it. They have in the pocket aspirin. And so we continue to give it even after stenting, but the evidence is, that's why we are planning to do this aspirin-free after discharge trial.
Okay.
Thank you, Adnan.
Thank you, Adnan. I forgot to mention that Adnan is also the mentor of the design a very, very nice DES platform combining the Probucol with Limus, and he showed a very outstanding results in reducing MACE and each component of MACE in a diabetic population. So I think that could be a very good good device to use our diabetic patients.
Alfredo, if you are successful with your trial with CECI, then we don't need it. We don't need it.
Okay. Thank you, Adnan. Thank you, everybody, to be here. Thank you. We have to move forward, and we will back again at 2 o'clock with the structural heart disease. Thank you, Adnan, again. Bye-bye.
Bye-bye.
Volvemos a las 2 de la tarde con aórticos y mitrales, y después que va a hablar Ron Waxman de Washington, y después tenemos la charla final de coronarios entre un cirujano de la Cornell University. Así que bueno, nos vemos en un rato. Hasta luego, gracias.